Dias.
Hello, good morning. I'm Alexander Lemgruber, evaluator of access technologies from Pan American Health Organization. My greetings to all of you. We are just waiting for others to join in. We have over 100 participants already in the group. So we'll be waiting one more minute and then we shall be starting our webinar session. Thank you so very much for being with us today.
Muy bien. Creo que entonces se ponemos.
Excellent. So I believe that we can get started now with our RedETSA webinar number 36, which is Latin American experience in the assessment of sanitary technologies in hospitals. I hope that those of you here today may have participated in the number 35 edition held on May the 19th, also on the topic evaluation of sanitary technologies in hospital, with a very brilliant participation of Marisa Santos and Laura San Pietro Colon. We started discussing this topic, a subject matter for which there is tremendous interest in the region. We had over 300 participants at that session, and this is therefore the second one within this series of webinars that we have prepared together with the members of the RedETSA, the ETSA network. And today the idea is to discuss concrete experience in given countries and institutions which are dealing with this topic of the assessment of sanitary technology in hospitals. Before starting the panel discussion, you may see the names of the panelists that we'll be having today that I will be introducing shortly. Some technical issues have to be mentioned. We have two simultaneous interpretation channels, which are English and Spanish, which you can find in the small globe that is in the lower part of the screen. We will be recording the session, so for you to know that the session is being recorded, and as you know, this webinar session will be made available to you on the RedETSA page and in the YouTube channel of PAHO. Before starting, expressing our gratitude so that we don't forget at the end to all those who are participating. I will not mention all the names, of course, because there are very many, but all the participants, members of our team, the administrative team, Ilio Baham, Frank, all those who always give us their support, as well as the technical team. I will be mentioning Malin Holman specifically. Malin Holman, our colleague, who provides all the necessary support and organizes all of the activities in the secretariat of the RedETSA. Our expression of gratitude to Malin, without whose support it would be impossible to pursue and carry out these webinars. And all the team members who are here with us today doing different tasks. I will not mention everyone. Therefore, we're going to start. We have three panelists this morning who have a lot of experience. We have Graciela de Mirjan, coordinator of the unit of the ETAs in the Garajan Hospital in Argentina, Virgilio Feloc Rojas, evaluator of the functional unit of the ETS and the National Institute of Neoplastic Diseases in Peru, and Vanessa Taik, Director of Economics in Health at the Albert Einstein Hospital in Brazil. She will be speaking in English. I tell you this ahead of time so that you are ready to listen to the simultaneous translation. We don't have a Portuguese channel this morning like we had in the previous meeting, so it is important that you know that we don't have Portuguese. Therefore, we're going to start. I think this is all the information I was supposed to be giving you. So I would like to move on directly to Graciela's presentation. I have her bio, and in just a second, I will tell you the information. I would like to invite Graciela Termillan, pediatrician, with clinical effectiveness, a coordinator of the assessment unit in the pediatrics hospital, Juan Graham, a coordinator of the assessment committees for medication teams and medical devices, director of the yearly course for management and pediatric research in the Graham Hotel at Hospital, and the public Argentine network, the RedETSA network, member of RedETSA, of course, and Graciela, who's a member of the subgroup interested in the evaluation of technical of sanitary technologies as part of the HTI. So with much pleasure, I call on Graciela now for her to make her presentation. Go ahead, Graciela, you're recognized.
Buenos días.
Good morning. Thank you very much for this invitation. I hope that you can hear me well. I will be sharing my screen with you. We can hear you very well indeed. I will try to share some of my experience in this last 20 years in the Gallahan restaurant and the sanitary technologies section. We are dedicated to developing this activity in hospitals. Some specific cases, of course, which may be helpful to others to know how to tackle them, how to deal with them. To begin with, let me tell you about our hospital. It's a very large hotel, pediatric hospital, and of national and regional nature, over 500 beds of intensive intermediate care, a very large number of personnel, much information. And despite it's a public hospital, it has the basic peculiarity, which is self-management. So it deals and manages its own budget. We take care of over 50% of patients that have no social coverage. And here you can see some of our figures that show the tremendous assistance pressure we have. This generates a great demand of equipment and medical devices, and also a very large variability in the utilization of these technologies. So to avoid chaos, this hospital, this tool in the hospital is a tool that we can indeed use. To give you context, and for those of you who may not have a chance to listen to the previous webinar, each hospital has its own hospital context, its own infrastructure, organization, human resources, patterns of care. And although this technology comes through hospitals because of its high level of complexity and has to be aligned with the hospital strategies, the speed of this technological development makes for us to have a multiplicity, plurality of these supplementary technologies which overlap over one another. Think of the many models of catheters, of medications, and of course other applications we have, and about which sometimes we don't know what is the real added value that these technologies possess. In many of these cases, it is necessary for the operator to be well trained so that the technology will work. Otherwise, there might be risk for patients. And of course, the cost that this imply for the healthcare system. There are two words that I would like to highlight in this slide. One is the context. The hospital has been, this condition has to be adopted to each hospital. And whether we have this element we have to use it. In the Garen Hospital, we started a program with 4 pillars: the assessment of the technologies, so that technological development be rational, but also in order to ensure the adequate utilization, evidence-based, of technologies that were already being used in the hospital. The second pillar is a technical practice, drawing up guides of pediatric attention based on care, um, according to the experience that the hospital continued to develop on complex pathology. Third pillar is the actual training of the professionals on subject matters such as research and management. And the fourth pillar is advice in the drawing up of guides and the research of services. Laura Samprieto mentioned in the previous presentation what we call the Olympic system. The first one to arrive would be the winner, the one that ran the fastest or jumped the farthest. Now we have at the further and more developed stage where we have evidence, but if this is biased or incomplete, as opposed to incorporating the technology which is being requested. In 2001, we started this process, and until we get to the ETS units, you see that we have changed our agencies. First, we have the coordination, quality coordination, then the Office of Teaching Coordination, and then the highest technology department in the hospital, which was related to hospital care. And we also changed our human resources. I began as a part-time professional in the burn unit. Then I was in charge of coordination with the committee, and then the establishment of the actual unit in 2018, where we have full-time professionals, part-time workers, and we had the medical technologies department to bring together the management of the equipment together with the assessment and evaluation. In 2022, this department now hinges on a specific coordinating unit. This is the structure of the unit, where you may see the 2 coordinators of the sector of evaluation of medications and that of medical devices, and the 3 committees, one for each one of the coordinators, and the committee for pediatric units. Beneath you see some of the services and departments with which we interact. Our process of care is a true cycle that undergoes 4 phases. The first is prioritization in order to incorporate new technologies, and this is based on the order of arrivals, but also the degree and urgency of such incorporation. For technologies in use, this is an activity carried out by the unit by reviewing the use of these technologies, particularly those that have a very large variability, high risk, or high cost impact. Assessment is taken with a methodology you're all familiar with, but I would like to say that this is done together with the users and other interdisciplinary committees that deal with this activity. The discussion takes place by ETS reports when these are addressed to the decision makers, basically the so-called direcciones, when they are directed to professionals and users through the clinical practice. This has to do with control of use, whether this is adequate, not how much is spent on medications, a new prioritization by closing the cycle, and sticking to recommendation, the guidelines, and also the collection of data in real life to see what are the actual results. In 2010, what commonly was an informal talk with users to contextualize the technology, a standardized document was elaborated, which is similar and adapted to the hospital. And here I would like to close this slide and tell you further that the user fills this form as an exercise that we deem the exercise should carry out. Then on this form, we conduct the complete assessment. The user has to put the generic name of the technology that he or she is requesting, both in Spanish and English. They must have for what purposes they're going to be using, what number of patients or cases or procedures that are going to be using that technology, something which is very important for the assessment of the budgetary impact. Also, in what way is this going to be used as a total, partial, or in addition to the technology? How is it going to be used? And the sector, which is very interesting too, and because the user has to say how he became familiar with this new technology and what other centers are using it as well. Finally, sector D, which is what is technology, not just with regard to the patients, but also as regards to professions. For example, if training is required, this will reduce their time of work, hospital organization, if this has to do with the number of hospital beds concerned, and also the effectiveness, evidence, and cost effectiveness, contributing with the local costs of such technologies. This is one of the most important aspects of the technology in this exercise, and I take charge of this activity because sometimes professionals do not know what is the actual cost of the technologies they use. The form goes to the office, deals with it. It is evaluated by the coordinator in the sector and reviewed by the committee. And the final report then will be sent to the office so that the service may be coordinated. Report may have 4 types of recommendations. That technology is not incorporated for now. The technology will be incorporated in an open manner or for restricted use or under a research protocol when there is no sufficient evidence and that the hospital may generate the information. This is a two-way path where sometimes technologies come in as a protocol of research, and members in the network that participate in this committee that reviews the research, we are in charge of this network and its protocol. This is our internet page where we have placed the evaluation reports. We do not disseminate them openly. Laura already discussed some reasons why this is not done so as regards reports of the hospital, but also not to promote indiscriminate use within different and various contexts and situations of high complexity, and not to promote situations that may be conducive to stopping the demand by patients and their families. Time of response is always 2 to 3 months as an average, but this has a very broad range. Sometimes it is just a few days when we're dealing with a rapid report with a concrete situation, or several months perhaps in cases of evaluation of the impact that the program has. Recommendations of incorporation is low, and the incorporation of decision makers is large. This was then, therefore, our first technology with which the program was started in 2001. Several items were incorporated. I finished my master's degree, and I was lucky that the director told me, what do you want to do with this now? And at the same time, in the unit of burn patients, where they were dealing with safety issues, there was a meta-analysis of collaboration where there was highlighted the potential risks for the dying of certain subgroups of patients, such as burn patients. We developed the CIME report, which is the first one, which is in green, which was done up by pharmacy, and we used it at the institutional level. With this, users knew that we were assessing this topic. We were able to reduce the consumption of albumin, particularly inadequate utilization, where albumin is absolutely inefficient. For example, albumin in solutions or therapy. For many years, this was maintained constant, and as happens, consumption then increased. It surpassed the initial consumption a year where there had been a substantial increase in the price of albumin. Therefore, we decided to prepare complete guideline updating the earlier one based on the web, and also a new intervention that we carried out in 2016 by updating the guide. This is the proactive activity, control of also medication. This is the top 50 ranking. Gamma globulin for over 10 years, it was #1, and there was a tremendous variability in its utilization. It took about 20% of the total expenditure for medications. The hospital concentrates many of the immunodeficiencies in a critical pathologies. The Senate 2006 bulletin, based on evidence up to date, there have been published very many new articles on many diseases, and I must tell you that the protected time of the pandemic allowed us to conclude the guide for the adequate use of gamma globulin in pediatrics, whose impact is being assessed at present. All this methods is based on the GRACE system, connection with experts is reviewed by payers, and they are of open access because besides being in the internet, they appear on an internet page that you can see down here. And this figure that you see over here is useful to know what is the impact, how many hits have been recorded in the web. Another significant case, and one of the few ones where we use cost effectiveness, is that of a diagnostic method. After the conclusion of a research protocol where PCR was done to detect the Escherichia coli, interhemorrhagic and no diarrhea, the information was required to pursue this strategy. Whenever we conduct this cost effectiveness analysis and budgetary impact, the low risk group, as happens in any area for children, this implied a very large cost for the hospital. Here you have the figures for that year, and view of the low incidence of both that germ as well as the Zoom. Therefore, cost effectiveness was quite low, not for high risk and bloody diarrhea, where we were managed to reduce the budgetary impact by tenfold and increase the detection of this germ. And this is the information that we were able to collect. Other neurological cases, we were able to determine the specific cases. One was the medicinal cannabis 2016 pathology that was used in the hospital. The clinical essays were randomized, had not appeared yet, or utilization of the regulatory agency for its utilization as a pathology adjuvant. So we developed a research protocol that was approved, respective cohort and not a clinical assay, in order to be able to recruit those patients that were obliged and mandated to do self-cultures. And the results by the first year were quite good, with a global response of 80% by the second year also. And here you have the explanation of where this is to be found. It was at 21 finding these results and the reassessment of evidence for that period where its use was recommended as an adjuvant.
A case that is known to everybody. This is for epineal muscular atrophy that has a high cost for their health system, which is administered for life. The hospital concentrates a large number of patients with spinal muscular atrophy, and the annual cost per patient is equal to 10% of the annual expenditure in medicines at the hospital. And if we consider the 70% eligible that we had at the time, without considering the new cases that could be diagnosed and an induced demand, the budgetary impact was unsustainable because it was almost equivalent to the 20% of the total budget, annual budget of the hospital. This was sent to the ministry in Argentina to consider this as a health policy. And I believe that during the first assessment that was done by our agency with this. Here you can see the webpage of our training course that already has 400 students that participate, and that continues. Therefore, we speak the same language, and some are devoted to management, others to research, and others wish to participate in technology assessment activities. So what did we learn? Well, we learned that it is desirable to have technology assessment in hospitals, be it public or private, or self-management, but this takes some time because we have to change the hospital culture and let people know about the efficiency at the helm, and that this efficiency is in our hands, in everybody's hands, and we have to work with users, with opinion leaders in other disciplines and committees, and we have to earn the respect of users and management at the hospital. This is only possible if the process is standardized, transparent, and objective. In some hospitals, we can also develop the evidence. And what I wish to highlight, which is an idea that for us is practically essential, is continuous monitoring of the technologies that are already being used. These are also technologies that have to be assessed and reassessed. So what are we fighting against? Well, bad habits and the myths of professional sectors and doctors who refuse to be controlled and audited, with the number of resources that is always scarce regarding those that are devoted to this, because they do need specific training, with a permanent turnaround of professionals that are being trained, and which forces us to update the guides and interventions as well as other strategies, so that following the guide would be good. And a problem that is quite unique to pediatrics, and in particular high complexity hospitals, is that many a times a decision has to be made in conditions of urgency or practically without any evidence. To conclude, let me show you that there are many models in hospitals all over the world that can be consulted, that can be copied, that can be adapted, and which are very interesting. The HTA in 2009 conducted a survey, and they classified these models, which is very interesting to see this, because you can take a look at all the different stages that we went through. Each one would have to find its a niche, its a model, to adapt it or to give it some order and develop it. And to conclude, let me recommend that this book that was written by the group of HTA hospitals, where we have a lot of experiences that are very interesting in our publication 10 years later. We are waiting for the one that is 20 years later. Thank you very much. Thank you very much, Graciela. Excellent presentation. We will keep the questions until the end. Then we will have the Q&A session. So thank you very much. And now we go directly to our next panelist, Virgilio Failoco Rojas, a physician, a surgeon, a graduate from the School of Medicine of the National Pedro Ruiz Galgo University, and a master's in science and epidemiological research in the Cayetano Heredia in Peru, assessor of the functional unit of HTA of the National Institute in Peru, has participated in assessing health technologies in Peru. Virgilio has performed publications, scientific publications and research, and his interest is in non-communicable diseases, particularly cancer, oncological. So I wanted to welcome you and to thank you, Virgilio, for your availability, and I give you the floor. Please, Virgilio, please proceed. Good morning, everyone. Thank you very much for that introduction. And this time we will be talking about the experiences, particularly at the INEN, the Neoplasia Institute, and we have the advantage of being able to share with you and to participate a little about this. And I wanted to start off by expressing that I don't have any conflict of interest in giving this presentation. And I wanted to introduce the National Institute of Neoplastic Conditions or Diseases. This is an institute that is located in Trujillo, the capital of Peru, in Lima. And this is a broad institute. Currently, it was built in Terra Nueva, where we give outpatient therapy. We have 16,000 new patients a year, perhaps a bit more. And we have 44,000 patients between new patients and others that come regularly a year. And therefore, when faced with the growing demand of patients, cancer patients that are being covered, taking into account the growing need for the inclusion of the new drugs, this unit, the functional unit of evaluation, was created in February 2020, exactly on February 20th, where activities have begun in March of 2020. And you will know already that the pandemic has started around that date. Peru, around that date, started facing the situation, and some units had to be shut down. But this unit was not prevented from continuing with its activities. Although it was a somewhat difficult year, and I will tell you about the beginning of the year, because there was no time in which we were not able to coordinate this adequately, because we were doing things virtually, getting the team together, and we were also able to conduct the activities. Currently, we have 4 members of the staff, one which is an oncologist, one general physician, one economist, and one administrative staff. And we have a physical environment within the institute, the INN, of which I showed you the picture at the beginning. This is a team we have. We have the director, Dr. Alexis Holguin, and as you will see, we have here the people that I mentioned previously. So regarding our current roles in 2020, we carried out these activities for the assessment of health technologies, and I will mention a few. Develop Health Technologies Assessment, and we essentially focused on medicines, devices, and medical equipment. All those medical and surgical procedures also that are performed and that are organized within the activities of the institution, and everything that has to do with the use of these within the institution, when you require prior assessment of scientific evidence in order to be able to make a decision. Besides, we also had as a target to assess health technologies, considering aspects of safety, effectiveness, security, and not only that, but the cost effectiveness. And I will go into this later on, how we've been growing, first of all, basing things on studies, then conducting a budgetary impact analysis, and then by conducting a cost-effective analysis, also to assess the economic impact that this might have at the INN. Then we have internal activities such as developing the annual plan of these to prioritize, and some other things such as assessing the available evidence. We can assess the health technologies that are required by other users that are new for the entity and that have not have any financial coverage by the IAFAS. So any drugs or any medicines that we wish to bring in or to include that are required by the different departments at an institutional level, we have the option or the possibility of conducting the evaluation in order to look for the best available evidence. And something that we're also doing currently is to assess the existent health technologies in the entity and to propose if there is a medicine, a drug that is already being used, to look into the situation to see whether it does have an efficient use and whether the use indications according to which it is being administered exist at a global level, whether we have current recommendations or whether this has been amended or whether we need to change to another technology of a better efficacy and better cost. And for that, for example, initially, at the beginning, we conducted the manual for procedures, the MAPRO, and this was done by Dr. Price Hill together with the entire team. We developed this manual, and initially each institutional agency or unit or organic department, each unit, institutional unit, for example, pediatrics, or maybe oncological medicine, requested an assessment of a health technology. So the units of the FEN or the HTA convened a meeting of interest groups. They brought a question to our attention with the population, with the intervention and the final result. And then we conducted the systematic search. Why? In order to look for the best available scientific evidence. And this was already part of the activities in the FEDS itself. And the activity or the advantage that we have as an institute, be it an administrative institute and an institute that looks after patients, which is an advantage that is given in comparison with other institutes that also perform these activities, is that we have at our reach oncologists, physicians that are participating, that are there present in the field, besides taking care of the patients. What we did was to meet with them to analyze the peak search, look for the systematic search, and then to select the best available evidence in order to show a table showing the summary of evidence. And with the committee, with the HTA committee, and I will present this later on, the committee was made up by a team that had the decision-making power, that is to say, voice and vote. So the document was presented, and with that, we analyzed a good share of the evidence. It was presented in order to arrive at a conclusion, a decision. And once we had approved this report, it was obviously submitted to the final report that reflected all the available evidence. And once we present the final report, we decided whether it is approved or not. If not approved, then that was the end of it. And if it was approved, the technology to be included, the final report had to go through a resolution. And later on, the planning team, including in the institutional territory, the health technology to be performed. This slide contains something that is interesting, which is the evidence, or that reflects the rapid review, the first review that we performed at the HTA. And this was assessed by Dr. Marina, I apologize, where, as you will see in 2020, this was a rapid review, the use of tislelizumab in treatment of patients with COVID-19. It was necessary to perform assessments within the field of COVID because the pandemic changed everything for all of us. And so ultimately, to date, ever since that assessment, we did not have sufficient evidence in order to prove the efficiency in cancer patients. Obviously, that was interesting. And this is how we received many other assessments and requests that we obtained over time. But this was the first one. It was published on September 16, 2020. And over time, we've changed a few aspects. This is a format that we follow of Health Technology Assessment that has these points in each one of the documents as chapters. And now we're on improvement. We're including or implementing a new format that includes additional information regarding the methodology, more information about the assessment of how the decisions have been made. We have the grade tables and also assessing the decision. We're also including this, and we hope soon to be ready to introduce the new format that will be followed by the institution, and for communications and information to be more transparent. And as I was saying, at the beginning, we developed this, and the framework was very helpful in order to have the information and to have the correct information on process flows. And once we presented this report, we conducted sessions on health technology assessment. As you will see, we're made up by each one of them, the institutional head, the executive director for planning, the Director General of the Office on Planning and Budget, and each one of them that you can see on this list. Also, we had the participation of the users, that is to say, the area that requested the equipment or the technology that was necessary. And together with the people responsible for HTA and physicians that assessed the HB-HTA. They don't have a specific vote on the decision-making process because they cannot be part and parcel. We did not have a vote on the final decision in order to have the report that we presented to be assessed by external people to what we presented. So any modification was taken in an extraordinary or special session. 2 sessions were held for the presentation of it. One first session where we had the information that supports the relevance for public health, the reason why the assessment of health technology requested is being conducted, a description of the technology, that is to say, to describe the technology, what is it about, how this is being evidenced, what was the advantage and disadvantage, amongst other things, and the strategy for the search for information, the summary of evidence, summary of cost evidence. And this is very important because this has already been changing. Initially, as I was saying previously, we've conducted other studies, but we've included this with a team of economists. Initially, we had 2 economists. One was able to get a fellowship in Argentina, and so we only have 1 economist currently working. But since we've been growing with a budgetary impact analysis, and in the future, we also want to have cost impact analysis in the institution. Then the summary of the regulatory status. If it is included by the General Department for Medicines in Peru, DGMID, if it has their approval or not, and the summary on availability and conclusions. This was done in one first session. Ultimately, there was not one vote per se, but what it was a comment, a discussion. The team had to understand essentially whether the evidence was clear, whether we agreed with everything that was being presented, if it was believed that something was omitted in the methodology, and then we carried out or conducted a debate. After that, in a second session, we held a second session to assess the summary of the HTA that had been presented during the first session, a value framework for decision-making, the votes, and the final decision, which I mentioned previously. Those who had a right to vote, and then the final decision was made with everybody together. When we talk about the value framework for decision-making, we were based on some criteria. And this is the first criteria, which is the theoretical part of it, and the second part would be the vote in itself. So we were focused on the burden and severity of the disease, according to the epidemiological data available of the Institute itself. Because in addition to that, we have an area that deals with the statistics and technology, so we can get data from there on how much disease burden has the disease that we're assessing. For example, metastasis in prostate cancer, lung cancer, small cell carcinoma, mutations or not. We have studies that are conducted as prior studies in Peru. And then the effectiveness of the technology to be used. If it had the magnitude and the relevance of the clinical benefit. The clinical benefit that we were talking about, the general in progression, the life as well as the quality of life, SG, SLP, or the rate of response according to some assessments on pathological response. Then the security, we spoke of adverse events. If the new technology could have serious, complex adverse events or not. The quality of the evidence of what we had found, high, moderate, low, or very low. And then the impact on equity. Implementing the technology could have a positive impact on equity, that is to say, where everybody could benefit from it, or not having an impact, or it was only going to benefit certain groups only. Then economic studies with cost effectiveness and the budgetary impact that was done through a budgetary analysis. So these are the points, and I'm showing this in general, those that were taken for the votes. The same thing that I said previously regarding the value framework, benefits, desirable, undesirable, and whether we reached a final judgment. This was done by way of a summary, and we saw where this was headed, if it was more in favor or whether the final vote was more against, according to the points that were established here. I know that it's only a few points, but it was very useful in order to make the best decision and always in favor of the patient. I apologize for interrupting, but you have 3 minutes to close. Yes, of course. So briefly, hand in hand with this, I simply wanted to say that currently, in April 2020, this was created. The National Network for the Assessment of these technologies, RedETSA, was created. It has to assess the requested health technologies of pharmaceutical, oncological products not included in the national territory in Peru. So this framework of RedETSA is currently being changed in order to assess devices or assessment of health technologies that are of high cost. So the HTAs, and I'm currently talking about HTAs of pharmaceutical products that are not oncological, are not in the hands of these products, not PNUME, that are assessed by the Health Technology Assessment Unit. We are awaiting to be able to join them and to be able to cooperate with them, because in RedETSA, different from others, is that INEN, HB-HTA has at its disposal the participation of physicians, a specialist in oncology, where they can cooperate and have a greater participation. And here you see this request, the application. And to conclude, we currently have what we do, which is that for the presentation of an assessment of health technologies, you have to submit a request through this annex, and I will not go into the detailed description, but we need a description of the health technology, how many patients will be benefiting from this, the time of the technology in the market, and some important pieces of information that could be considered, such as specific benefits that the entity is requesting. And for that, we meet and we debate this and we present it in a final report. In the experience, these are the HTA published, 69 so far until March of 2023, and the technical reports, which are 55, and these have been developed in the last few years. As best practices, we've had achievements, certificate of best practices by the group of citizens, an NGO that acknowledged the work we do in 2021, joining RedETSA, that was also in 2021, and a flow chart that is proposed for the application of, or the request for these health technology assessments. This is a flow chart proposed for the HTA. It's in the hands of each institute, but it can be submitted and then make the right decision based on the requirements that they need for the HTAs from the hospital point of view. And we hope in the future to continue promoting an institutional agreement between the Peruvian networks and also to support institutions in the region through RedETSA and to strengthen the decisions of the MBE. This is our webpage, and we hope that the experience that we're having will be strengthened and will be greater each day. Thank you very much for your attention. Thank you very much. Thank you, Virgilio. Excellent presentation. We can really see how Peru is doing with this, a country that is going through a very dynamic process, many significant institutional changes, very dynamic, including the work that is done by INEN. We're very happy that INEN is a member of RedETSA since 2021. So thank you very much for your participation. We have some questions, over 160 participants already. And let me remind you that you can include your questions in the chat. We have the Q&A and the chat. And then after the third presentation, we will open up for this debate and the answers to the questions that we have here. So I will invite you to listen to the next presentation, and please include your questions in the Q&A or in the chat. Let us go through the last and third panelist, Vanessa Taik, production engineer from Rio de Janeiro, with a postgraduate in economic assessment, director of health economy, a PhD in England, worked for 3 years as a consultant in the assessment of new health technologies, and currently is the director of health economy at the Israeli Albert Einstein Hospital in Brazil. Vanessa, it's a pleasure to have you with us here today. So please proceed. You have the floor. Thank you very much, Alexandre. I will speak in English, so I will switch now to English.
First of all, thank you for the invitation. We are just starting this experience. Actually, the plan when I joined Einstein in 2019 was really to have developed, we should have developed that starting in 2020. We started planning for that in the beginning of the year, but then the pandemic started and then we had to postpone that. And we really restarted the process last year. We approved the policy at Einstein to implement health technology assessment first in our private hospital and then in the Einstein system as a whole. That's the plan. So I'll share our initial experiences. Just to give a brief background about Einstein, we're well known for being a hospital, but for the last years, we have evolved for being a health system, actually, as we call ourselves. Currently, we have 21 private healthcare units in Brazil, 2 hospitals, one in the city of São Paulo and one in the city of Goiânia. It's the center west of the country. And in these private hospitals, we have around 770 beds in total. And in the public healthcare system, we have 30 units that we manage. We manage public units in Brazil as well. Among those units, we have 3 hospitals. In those 3 hospitals, we have around 900 beds. The initiative I'm going to tell you about is starting in the private system, because in the public system in Brazil, we have a better structured process for technology assessment, and in the definition of what is covered comes from this central assessment by CONITEC. In the private system, we also have a process for evaluating new technologies developed by our private healthcare agency, but there is still a lot of room for evaluations of the practices that happen inside of the hospital. And that's why we decided to create this new area at Einstein. And when we started discussing what would be the role of health technology assessment in our system, that would be mainly to identify the new opportunities for technology innovation to be incorporated into clinical practice, and also to have a place where physicians or departments could go to and ask for the assessment of a new technology. We have the plan, and we've been doing that, involving clinical specialists in the process of evaluating and incorporating the new technologies. The group evaluates the best available scientific evidence in a technical and transparent way. And the aim is to maximize the expected clinical gains for patients from available resources, because some of those technologies that are evaluated are technologies in which we as a hospital have to invest, for example, to acquire a new equipment. And we see the role of this group as well to support and monitor the implementation of the approved technologies and of the results achieved, because sometimes technologies are incorporated and in the end, we don't know if the use has been the same as it was planned, if the results were good as we had expected. So the role of our area as well is also to follow patients that are using these new technologies, and also the role to disseminate information related to the benefits achieved with the incorporated technologies. So much of this is still an intention because we have just started this process. That's where we want to go to. And at Einstein, what we've been developing is creating kind of technology radars in our departments. So requests for new technology evaluation can come from innovation committees. We have some of them in the assistance departments. So for example, one in oncology, precision medicine, surgery network, but it can also come directly from the clinical staff, from physicians that go to a meeting and see a new technology and they want us to evaluate that technology. It could come from the supply team and from clinical engineering. Actually, we don't restrict any type of submission, but these are the main areas where we get requests from. And then there's this process of assessment that I will show you in the sequence, prioritization, which is under definition of the criteria we're going to use, and implementation. And our plan because we've just started that, is to follow the patients that are using these new technologies to be able to get also information about effectiveness when possible and costs. And in relation to the technologies that we believe that are going to be the scope for our assessment and the ones that we are already evaluating, and to show you how recent that is, we did our first committee meeting yesterday. That went very well, and so we're really in the process. But what happens is that since we're talking mainly in this specific situation about the private system in Brazil, there are specific rules to define which drugs and treatments are covered from private payers. So when it comes to injectable drugs restricted to hospital use, they are usually covered, especially oncology drugs, they are already covered. The drugs for other indications have some discussion and need to be evaluated, but there is this specific process to define coverage. So usually we don't get involved in the evaluation of those technologies, which is different from what you have shown in Argentina and Peru. And I think it's really interesting to consider doing things similar to what you're doing now. We're starting in the part of devices and procedures because we are a small group at this point, but I believe we can expand to do similar analysis to the one you've been developing. For oral oncology drugs, there's also a continuous update of the coverage list. ANS list would be the list that defines what is mandatory for coverage from private payers. So we also don't evaluate those specific technologies. And here is the part where we get our demand for evaluation. It's for diagnostic or therapeutic procedures, because many times we have new procedures that physicians want to perform, or we have new medical devices that are still not reimbursed, and they want us to be pioneers in developing those types of procedures. And there are also new equipment that our physicians expect that we offer to patients in our hospital. And in the end, we don't have the resources to invest in all of them. And we need to get information about safety of those procedures, expected benefits to patients, even to go to payers and try to negotiate the coverage, even if it's not mandatory. So those are the technologies that we're mainly focusing on in this new HTA flow. to provide information internally and also to payers about the cost effectiveness and the benefits that we observe from these new technologies. And it's also worth mentioning that we have an incubator for startups that it's called RedETSA Bio. There we have many startups that develop technologies for healthcare. And we have it's been about 2 years now that we've been doing that. We develop HTA studies, so mainly cost effectiveness analysis, and we help them build the reimbursement dossiers for those technologies to be submitted to public or private HTA evaluation. And in terms of the process itself that we've created, so as I mentioned, mainly the demands will come from a clinical staff or a department, the supply team, or the clinical engineering team, although it can come from anywhere in the institution. We have created a form for incorporation request. I saw the forms that you presented before for Argentina and Peru, and it's similar in the sense that we also get request information about the indication, the technology alternatives, the expected clinical benefits, the expected cost comparison. Usually physicians don't have that full information, but we ask them to provide what information they have. And part of the process, we are in charge of developing after that. They also have to declare their potential conflicts of interest. And then our team, the health economics team, is in charge of preparing the initial report. So we look at regulatory approvals in Brazil and other countries. This part of the critical analysis of the scientific evidence, so literature review, we consider doing that internally because we have specialists in the different diseases. But so far, we don't have a team that is dedicated to evidence-based medicine, fully dedicated to that. They do work in the research center we have, but they don't have a dedication specifically to health technology assessment. So we decided to outsource this part. And we contracted with EX from Argentina to do the scientific literature review. And we develop internally the economic analysis, which is simpler than the economic evaluations we're used to delivering to Conitec or to CoSaúde, our HTA bodies in Brazil. And then we came up with this committee. And I'm also interested to discuss this about this composition of the committee. I saw in the last presentation that Virgilio presented who votes, who presents. That's really interesting because we discussed the different alternatives for this composition of the committee. So as I said, we had this first meeting yesterday. So we got together, we presented, we had a time in which the person who was in charge of submitting the request presented their reasons why they believed that we should incorporate the technology. We presented the evaluation done by YEX and the economic evaluation we had done internally. And then we came to a discussion and to a conclusion about which would be our recommendation in relation to those technologies. It could be that we don't recommend the incorporation, and we created 4 possibilities for the results. It would be fully approved, so no restrictions. It could be approved for specific subpopulations, either because we have some restrictions in relation to the expected benefits or unproven cost effectiveness. The approval could be for, we're going to approve the technology, but we're going to follow patients that use the technology for 1 or more years, especially because we have limitations in the clinical evidence. And it could be approved only for research protocol. So when we have still improvements that can be done in terms of the evidence, I think we would go to this 3rd group. But when there are a lot of questions around efficacy, safety, and we consider the procedure experimental, then we would go to this 4th group of approved only into a research protocol. And that's where I think that we could collaborate more as a region in Latin America, because for sure, all of us will have the same challenges. And that's it, because in my past as a consultant, I was very much used to developing economic evaluation and HTA for drugs. And for drugs, when they come to a registration process, they usually have a more robust body of evidence in which we can base ourselves to develop a model. But when we look at diagnostic procedures, even therapeutic procedures or medical devices, the level of evidence we have available when a product is registered, at least in Brazil, and I think it's the same elsewhere, it's not the same as we're used to see with drugs. So how much are we willing to deal with that uncertainty to be able to provide that technology to patients while after it's already registered from regulatory bodies in Brazil? I'd just like to present one example of the delivery that EX does to us. So we send them a list of technologies we are evaluating. This is an example of irreversible electroporation for irresectable pancreatic cancer. For example, in this case, they evaluated that the level of evidence was low because of the design of the studies that were mainly observational studies, but the net benefit is considerable and that there is uncertain cost effectiveness because we couldn't find any published cost effectiveness. But the thing is, this is the main scenario we see with most of procedures, equipment, and devices we evaluate. So how are we going to deal with this uncertainty? And I'd like to list specific challenges we've been seeing for the hospital use of HTA, especially in the reality we're facing at Einstein. And that would be the maturity of scientific evidence, as I told you. And this is one of the points. And the other point is we want to be innovative and we want to be pioneers. And we have expectations from our physicians that we maintain this pioneer position. So we need to find a balance between that. Second is that we're still having a hard time finding prioritization criteria. And that's, I think, a challenge for everybody that deals with HTA. There is this competition between hospitals, and that's a scenario mostly in the private system in Brazil, that hospitals compete among each other for technology, for innovation, and for this innovation image that we have for our patients and in the system as a whole. So how we also need to balance that with the expectations of physicians and also with the cost effectiveness and HTA evaluation we do. And one thing that we're trying to do now is to integrate this HTA process with the annual investment decisions, because we're starting to use the HTA evaluations as one of the prioritization criteria for the investments for the next year. And that's, I think it's going to be really interesting to see if it's going to be really helpful and useful to prioritize the investments we're planning for the coming year by using HTA in the hospital. So thank you very much. And I'm thrilled to answer questions if you have them.
Thank you. Thank you very much, Vanessa. Great presentation, very clear, very interesting experience in Albert Einstein Hospital in Brazil and the Albert Einstein system, as you mentioned. Bien, vamos a pasar a la sesión de preguntas.
Very well, so let us go on to the Q&A session. But before that, I would like to mention a very important initiative that RedETSA is launching, which is directly related to this issue of our webinar today, which is precisely a survey on health technology assessment in hospitals that we are performing with PAHO, RedETSA. And we had, for that activity, the coordination by Marisa Santos. You all know her. She was a speaker during the previous webinar, and some others here today. And she's supporting us with this initiative with all her experience. And today, we're launching this survey, We will send this extensively to all participants of the webinar, to all the members of RedETSA. And this is a questionnaire that is quite simple. It's a questionnaire that is simple. It's a brief, quickly to fill. We have versions in Spanish, in English, and Portuguese. If you can answer in a group or individually, but we'd like to receive one answer per institution so that one same institution would send one response. So you can answer that together, but we want one answer per institution. Please send it to RedETSA's email, and you will see the email on the chat. You will see our institutional email for RedETSA, as Malin will include on the chat, and also to say that we will send at the end of today a message to all the members of RedETSA with this information. And also all those who participated in the webinars of the previous webinar and today. We had over 200 participants during the previous session. Also, during the previous one, we had over 200. And so we will be sending these to these people, those who work in hospitals. So please send us the answer. And those who do not deal directly with this issue, but you know that in your country, there's a work being done with hospital-based health technology assessment with this experience, please send this information so that you can complete the information. It is very important so that we can have a diagnosis of the situation in the region. I just saw a message that appears from the HTA in Colombia saying that you can count on them for this activity. So thank you very much. Going on to your questions, we already had very interesting presentations, but we're running out of time. And I wanted to ask our panelists, I see that Vanessa, Graciela are ready. Virgilio, if you can turn on your camera, please, and turn off your mics. Thank you very much. And since we have very little time available, I would ask you to, please, I know that this is difficult because we have a lot of questions, but there won't be any time to go through different rounds. So what I'd like to ask you is that I will read out the questions. Some are general, others are specific questions, and I would ask you to please take note of these, and then I will have one round of answers in the same order as your presentation. So we will start with Graciela, followed by Virgilio, and then Vanessa. And you will then give us your answer. I will follow the order that we have here in the Q&A. Some are in the chat. I've asked Marlene to please transfer these to the Q&A so that we can have all the questions in the Q&A. We have Andres Mejia from Guatemala, from the Institute in Guatemala. Greetings, Andres. And the question is, when performing, this is a question of a general nature, when performing a study on the expenditure of medicines and identifying the drugs that consume a lot of percentage of the expenditure of the institution, what interventions can be considered and where should these be addressed? Essentially, this has to do with the budgetary impact and what to do with the technology of high impact. Then we have Marisa Santos, and Marisa is asking, who approves the new medicines or equipment in your hospital? Is this a multi-professional commission or committee? Some have already answered this part, but we'll leave this a question which is addressed to all panelists. And then we have Pedro Krasnokuki, and this is a specific question for Dr. Demirdijan. And the question is, if a technology is rejected, or if it is only sponsored for a restricted use, how do you monitor compliance with what was decided? How does the hospital community respond to that? What measures do you have for the restricted use? So this is a specific question addressed to Dr. Demirdijan. But if the other panelists wish to include this, you're welcome. Angelica Ordóñez, how did we measure the impact on equity? How is that measured from a hospital point of view? very important issue, which is equity. Ada Escobar, what is the average time in order to perform a health technology assessment? Daniela Martinez, according to the experience of the presenters, do you believe that there's a criterion on the complexity that the hospital must have in order to implement a health technology assessment unit? So this is a question about the level of complexity of the institution for it to be possible to implement a health technology assessment, an HTA. Daniela Martinez, how can we complement the HTAs in hospitals with the assessment agencies at a national level? This is important, the articulation, because sometimes we hear, if we already have a national process, why have another one? So how do they supplement each other? And then Marvin Vasquez, what strategies would you recommend to train the staff? And it gives us examples of his country, Guatemala, where they don't have courses, postgraduates, for the development of these HTAs. Then the next one, a lot of questions. Once again, Pedro Krasnokuke, this is a specific question addressed to Vanessa. Same question, but only in English, Vanessa, about the issue of the restricted use, or what to do with this issue of restricted use. You can read it. The question is in English on the Q&A. And then we have Darcia Silva. The same question about the timing. How long does a working group take on average to evaluate a technology? And then we have Ada Escobar asking specifically about medical devices, if we have any specific methodologies for the specific issue of medical devices. And then another question about the time. So please confirm that the chat questions have already been transferred to the Q&A. Yes, unfortunately, as a panelist, I cannot include questions in the Q&A. It has to be done directly by participants, or you can read them on the chat. There's one by Elliot. I can see one from Elliot. How can we implement a private insurance company and an HTA department in order to make decisions and include health and technology in the plan coverage? Or is it only used in public hospitals or in public financial institutions? I can answer this. It is perfectly possible to implement an HTA in private hospitals. Even in the US, as you know, there is no national association for the assessment of technologies. However, the private health insurance is very strong. So there are assessment departments of technologies that are quite strong in the private insurance units in the US. So it is desirable for insurance companies to have their own HTA departments. And another one by Marisa, and I believe that this will bring us to an end. The use about free life of progression, it is controversial but necessary. How do you use the data about the free life and progression and the assessments that you perform? Very good. So I'll leave you with this. We have all these questions. It is quite a challenge. Obviously, we will go over time. I ask you for your patience. We will go over time for 10 minutes. I would ask for 5 minutes to each panelist. I know that this will be an impossible task, but to attempt to respond to most of the questions that have been asked or answer those that you consider to be priority questions. So let us go on to Graciela, 5 minutes. I said something about what we do with the medicines that require huge expenditure in the institution. No, the first thing we need to do is appropriate use. And for this, the electronic clinical history are sometimes incomplete. We can do a systematic things as we do with users in order to see how this is being used. And the intervention is usually addressed to reducing severity, that is to say, to make more appropriate the use of that technology, and if it is being used incorrectly. Regarding who approves the new technology in our hospital, I said that the approval is in the hands of the directors, and it's not one, but several, after the review of the review committee for each coordination sector in a unit. With the restricted use, this is somewhat similar to what we have with high-cost medicines. The first thing is to see whether it is being used adequately, whether the restricted use is being met with clinical history data and user data. The strategies for the restriction to be met many times have to do with looking into the possibility of prescription. That is to say, some drugs can only be prescribed by specialists, and then continuous monitoring, as we do with any other technology that has already been included. This is not a perfect mechanism, and physicians always get used to expand the indications, particularly on medicines. Regarding equity, I want to say that many a times what happens is that new technologies are indicated for patients that have coverage. We're talking about a hospital such as ours that is public, and that is absolutely lack of equity for prescription or the indication for drugs. So we attempt to perform the assessment as soon as possible in order for this situation to be avoided and for it to be an equal footing for all patients. So the average time is 2 months with great variability. Regarding the complexity that a hospital must have in order to perform HTA, Laura San Pietro was asked the other day whether a primary healthcare center could perform the HTA, and I believe that they can do it. A hospital, first-level hospital, could do HTA, but it all depends on the trained human resource available. And for that, we can follow some models, such as the one in Paris, where several hospitals, and I always say that this would be an ideal model for a city such as Buenos Aires, where we have 30 hospitals, where we can bring them together and assess this together, having one group, but perhaps external, made up by the trained individuals in each one of the hospitals. The relation with the national agency, in general, what happens is that high complexity hospitals, and this was mentioned by Laura, they receive inclusion requests for many technology that the national agency has not assessed. So in the case of ours, it would be one that I mentioned. And the assessment sometimes at the hospital is always triggering the need for assessment by the national agency. It could be the other way around. And many times we use this as a basis for assessment, the assessment by the national agency. And for the training of our staff through the virtual means that we have a lot of ways in order to train the staff in different activities that have to do with the assessment of health technologies. This is a training that cannot be superficial because the decision-making depends on it. So in general, this is quite vast. And for medical devices, there is no special methodology. But sometimes it is difficult to be able to get issues that assess one specific model. Sometimes it is necessary to assess a given brand or a specific model of a medical device. And the criteria that are used to assess these, there are very few that are randomized and they can follow the evidence that they have.
Thank you, Graciela. Thank you for sticking to the time. Virgilio, you have 5 minutes. Just to briefly say, as regards question, the expenditure for medications and medications according to percentages, this is a continuous assessment, a constant monitoring, and especially to assess whether the use indication is being followed adequately and the reason for which that technology was adopted. What are the possibilities to assess the burden of disease, the cost, see whether the technology and the medication for which you suspect that there is a very high expenditure consumption, see whether there is any new technology that might be effective, that would generate savings, or to specify whether it might be necessary perhaps to have a new use indication. With regard to the question as to who approves the medications, or is this a hospital team? As we said, and as I indicated, it's very important to have an adequate flow chart. Approval of the medication comes in the ETS committee, HTA, and the formal approval is then carried out. How did we measure the impact of equity? The impact of equity comes through the value framework. We base ourselves on great questions, where one of them is whether there are groups or subgroups that may be affected as a problem of intervention, or is there a way to uh, prevent or avoid efficacy? Yes, basically what we're assessing here is that there will be no subgroups, which by way of a certain technology would not be benefited by the clinical impact or the size of the intervention. If we are applying, let's say, an oncological high-cost medication, which is indicated with patients having a special mutation, not everyone will benefit, but just a specific group. But what we say in general terms is that all patients having this use indication which is being given should be benefited, should benefit from it. The average time to carry out this sanitation technology, and it all depends on the actual institution, its human resources. The average has been from 15 to 30 days approximately for each one of these sanitary technology. According to experience, there is a criteria for complexity. No, that is not so. It all depends on the burden that each hospital health care center has in order to apply this sanitary technology. In other words, each one of the centers will have to evaluate and see whether the resources are being well directed or whether they need to implement something else. In keeping with such needs and in the way in which they have conducted the assessment, they will perhaps need to have an evaluation. How can we supplement these units of HTS at the national level? We deem that we can articulate units because of several reasons. In the hospital centers, we have the advantage that there we have the cases which have been treated by means of the technology, and evaluation can be made, therefore, which is quite good, where we may see and obtain information. For example, regarding technologies that have shown negative aspects, or technologies which have not been approved, or other technologies which may have been approved already, but a reassessment is required to see whether in the world of reality such an assessment was positive or not. One thing is to see the clinical essays, and a different thing is to see what happens in the real world. So the assistance by hospitals may generate new evidence, and as a result of it, we can generate this information which is so useful. Besides, we have the experience, and as we saw it in the last slide, the MBA has certain aspects, not only the medical evidence. The MBA also includes the expertise of medical doctors, the preference by patients, and scientific evidence. This is a sum total of elements that has to be adequately assessed. What strategies would you recommend for training personnel? We have postgraduate courses, and currently the technology and the internet allow us to be in communication with the entire world. There are very good courses going on in various institutions which offer training. The gray manuals those of the Canadian institutes and so on. There's very good information that might be used and we can become trained. Not only that, but we could also consult or ask other experts. PAHO is indeed offering this webinar, which is very important, where you can share and socialize this information. This is the way in which we may be able to have better communication still. Then with regard to medical devices, and we see this in the report. I think that is all for now. Yes, thank you. Thank you, Virgilio. And lastly, we move on to Vanessa during 5 minutes, so to see if you can answer the questions. I will be answering in Spanish this time to facilitate things. I will be focusing on a question that has to do with the timing. For now, about 2 months are required to conduct an assessment, but we don't have many technologies that we are assessing as of now, but there is the intention that the group devoted to these evaluations may have more people. So in 2 or 3 months will be the timing in which we would like to conduct evaluations. We don't do such a complex evaluation as to we have a submission for Conitec. And the idea is that it would not be so complex. The other question was, how do we control things when the approval is sort of partial or has certain restrictions? When this is a medical device, the restriction cannot is you do not go ahead and not buy the device. So it is not allowed to use that device that we don't have in a given hospital. For procedures using a device which is already there or who may not have such a device, the control has to do with the actual programming of the surgery. So no programming is allowed. And in fact, when we speak about a certain procedure which has not been approved, which has certain restrictions, the number of doctors applying it is not very large. So it is somewhat easier to control its actual use. Yesterday in the discussions we held, we had an approval with restrictions. And for that procedure, patients have to sign a authorization of responsibility or liability, where they admit that the procedure is not under study, but it has certain limitations and evidence. And medical practice reviews the indication for the patient, and the patient has to bear in mind what is his or her responsibility regarding the risk that the patient will have in order to have the information regarding outcomes. So this is the way in which we control these partial cases for now. Another question is, how do you supplement the central and hospital procedures? As I said, that which has a central decision-making is something we do not evaluate in the hospital. Technologies we do evaluate are those that were not subject to an evaluation in the central HTA, or technologies that will not be assessed, because we have a certain procedure which is incorporated, but the medical devices individually are not being evaluated in general terms in the private system as part of a procedure. So, and as a general rule, there was an evaluation made in the central HTA, and then we do not conduct an additional evaluation. Another question is with regard to training, and this is something in which I am very much interested, because here in Brazil, we have professionals who are knowledgeable about the HTA, but there is tremendous competition for such professionals. So all the time we have to train new people. We have resorted to the RedETSA technologies. But what I think is that since all of us have this need, this same need, perhaps this hospital HTA approach might be a kind of a basic training for those who are only starting, because it's somewhat different from the traditional HTA that we're accustomed to doing in the past. That's all. Thank you. Thank you very much, Vanessa. Very well, then I acknowledge that it's impossible to answer all the questions, and I believe that this webinar is one of those that has had the most questions, which shows the tremendous interest by participants have regarding this topic. So once again, I would like to thank Graciela, Vanessa, and Virgilio for dedicating their time and preparing these presentations and being with us today. Also to thank all the participants. Later on, we will see the actual numbers. Some people have to leave earlier, others join later, but the total number of participants is something that we have to wait and see what is the actual information. But I'm sure it was more than 200, and I'm sure that at the same time we have had around 170 participants, which shows their great interest on the topic. I want to thank the whole team once again, the entire team, our interpreters who've done excellent work. Thank you so very much for supporting us with the language issue. And I would like to leave an invitation here for our next webinar, which will be number 37. It will be held on August the 11th. The time will be defined in coming days, but we already know what the topic will be. It will be a special webinar. For the first time, we'll be having a joint webinar between RedETSA and the Criteria Network of the Inter-American Development Bank. PAHO IDB will have thus collaboration through the regional networks, of course, in the case of RedETSA and the Criteria Network. For the first time, they will be together in a joint seminar. We will deal with the thresholds of cost effectiveness. We will be hearing Andrés Pichon Riviere, a very interesting piece of work they carried out by way of a recent publication. And we will be having some countries that will be partaking as discussions. So we will be announce this in coming few weeks. We will send an invitation to all of you, but please, you can reserve, you can book in your agendas, because it is likely that this will be a morning session in the same schedule as we have other webinars, but we will decide this together with our colleagues. For August the 11th, you can write it down in your calendar. And finally, people are asking about the recording and access to it. Let me remind you that this will be made available in our RedETSA website, as well as the YouTube channel of PAHOS. If you have any misgivings, please send a question, as I told our colleagues, where we have all the support by RedETSA and our secretariat, people from Argentina and the secretariat here in Washington and PAHO. Our team is always available. You can send an institutional email. And Marlene, you can confirm this because this is already in the chat. Is that right? Yes. Yes, Alexandre. And we are members. Turn on your camera so that everyone will get to know Marlene. There she is. So I take advantage to thank you all once again, and we bid you farewell. Thank you so very much for an excellent webinar session with very high-level questions. Thank you all for your participation, and wishing you all that you may have an excellent weekend with your families. Thank you all, and we'll be in touch. Bye-bye.